So I'll get started. You're about to see a picture of the three of us, and just briefly, if I could introduce, my name is Kevin Mahoney. I'm the Senior Vice President, Chief Administrative Officer for Penn Medicine. Been there for about 16 years. It is absolutely the greatest job in the world. I hope they let me retire from there. I'm lucky every day I come through to work with great employees, great scientists, great doctors. But the secret sauce behind Penn Medicine is Judy Schueler. Judy joined us several years ago, formerly in Chicago, made a little trip down to Scottsdale. The reason I think of Judy as our secret sauce is she has really arrived with an organizational development background, and she has retrained and repurposed a lot of what we're doing, and you're going to hear about that today. And then one of our future stars, Aaron Johnson, who's Director of Communications in our Innovation Center, is also doing a terrific job helping us communicate some of the things that we are working on. You're about to see a slide that has a lot of numbers on it that describe Penn Medicine. We are a large organization, about $4.3 billion a year revenue. We have 4 hospitals now. We're hoping to buy a 5th shortly. We have about 100 practices out in the suburbs. We have a large practice plan. We are the #2 rated school of medicine in the country, which we're very proud of. Not so proud, we continue to slip a little bit on the U.S. and News World Report. So we went from 8 to 10 to 15. So we have some work to do, and you'll see that get filtered out in the discussion today. I think importantly, though, let me just tell you a little bit about the culture at Penn Medicine before, just as a tee up to the innovation. So we were the first hospital in the country at Pennsylvania Hospital. So if you go into Pennsylvania Hospital, the front door is never locked because William Penn's will said that it shouldn't be. So you can imagine being in an urban setting with an unlocked door. Ben Franklin used to hang out down at Pennsylvania Hospital, and we have a lot of historic artifacts. So when people start talking about how hard it is to change your culture, you ought to try to change a culture that goes back 251 years to Dr. Franklin. We were also the first school of medicine at the university. I think there's a place in Boston that says they were the first in the colonies. I'm not sure of the distinction, but we wrestle it out with them, and we take pride in being the first school of medicine. We'll celebrate our 250th anniversary next year. The culture of Penn Medicine, though, I think is one on the health system side of being an execution company. So you give our management team something to do, and we run through the wall until it gets done. Unfortunately, it hurts sometimes running through that wall. So we were, back when we thought we were going to all be capitated, we went out and started buying practices. And we brought a consultant in who said, here's 800,000 covered lives that you need. Go out and get 800,000 covered lives. It came out to 318 doctors. That became our metric, and we went out and executed on that. And we hired 318 doctors in about 2 years. And $40 million later, we realized that was a mistake. So very much an execution company. Therefore, we make money and lose money faster than anyone I know. In the year 2000, we lost $200 million one year, and a couple years later, we were back in the black. This execution culture, I think, is what Judy has amended for us by teaching us a little more about leadership development, because we were very much one following the other as we go forward. It is also, though, a study, if I could just go back one more. On the scientific side, we had a death in a gene therapy trial back in the late 1990s. We have a Dr. Carl June who kept pushing and pushing and pushing, and we got back into the gene therapy game, and we've now signed a deal with Novartis for about $700 million for gene therapy, and we have proven that they can cure blindness in patients through gene therapy. So again, it's a place that has had great losses and recovered, great scientific setbacks and recovered. And what we're trying to do is prepare for this new population health and everything that we've talked about without going through some of those ups and downs that we had. So we have worked on our landscape, which is going to be difficult. We believe fee-for-service medicine will stay. We just think the fee will get lower and the episode will get longer. But we don't anticipate capitation or a lot of the risk contracting to take place in the Delaware Valley and Philadelphia. Important to us, though, is we've been overbedded in Philadelphia, and things are quickly moving to the outpatient side. So again, trying to take an organization that focuses on the inpatient side and get ready is part of what we've talked about. Our innovation center is important to us. Judy's going to go in a little more detail, but we decided we ought to bring in some new talent. So you're going to hear we brought in the Chief Innovation Officer from Intuit, joined our group, and Roy Rosen was able to get Quicken Books and TurboTax started. So we said, if you want to have a challenge, why don't you come work on healthcare and see if you can help us innovate some new products. We also brought in a lot of behavioral economists from the Leonard Davis Institute at Wharton to help us with some of the behavior change that we've all talked about a lot. Most important, I think, is our framework. So we do want to reduce our costs naturally. Everybody in the room does. But we want to focus on the how algorithm and the what algorithm. So how do we get our processes improved, which all of us are trying to do, but also on the what side in terms of innovation. So we've been struggling with our breast cancer service line. We only have about 3% of the market. Doesn't seem like Penn should have a little bit more than 3% of the market, since our overall market share is probably approaching about 30% in the market. So what we went through on the what algorithm is a new way to look at breast cancer, which is we only want to treat secondary breast cancer. And we have a team of scientists that are working on circulating tumor cells as a way to predict whether or not secondary breast cancer will reoccur. And we think that's our niche as we go forward. If you go into an ACO model, if you go into population health, if we can identify and treat that disease quicker and faster than everyone else, we'll have a place in the marketplace. Most importantly, though, we're going to hear a lot about experimentation. When I said we have a culture that runs through a wall, we standardize everything and we follow that religiously. Again, even if it's wrong. So if we change something in Epic, we change it for 2 million patients. We don't change it for a handset. So one of the things, again, Judy's going to talk about and brought to us is how do you do rapid experimentation without reinvesting a whole lot of money so we can measure the return. If it works, cycle it out quicker than we have in the past. With that, I'll introduce Judy.
I'm going to just spend a couple minutes talking about the pathway that we've taken. And some of this, I think, is a common theme that you've heard through other leadership development. But our real focus was to increase our capacity for continuous improvement and innovation. Now, in an academic medical center, innovation isn't new. You know, we have scientific discovery every single day. But as you well know, scientific discovery at the bench takes about 10 years to get to the bedside. So it was really building that capacity not only in our research enterprise, but in our clinical operation enterprise as well as our School of Medicine. So with that, the conversation started way back in 2008 in a collaboration with the Wharton School of Business that we're fortunate to have on our campus, that we really brought our senior leaders and our clinical leaders from across the enterprise to really focus on building 4 skills. And those skills are under the umbrella of innovation and scenario planning, rapid divergence, problem reframing, and persuasive selling of ideas across the traditional boundaries of one's job and one's department and unit. So that was a linchpin because it actually led us to this discussion around revolution. So healthcare reform's a revolution, right? And the first thing that revolutionaries do is they seize the schools. So like so many of you have really embraced a corporate quality university type of concept, so did we. And we call that the Penn Medicine Academy. And that's where our leadership development offerings are held, as well as driving that learning lab to the front line. And you'll hear a little bit more about that later. Other things that we accomplished is that we didn't want to just build knowledge. We really wanted to kick in action learning. So our action learning model for leadership development, we call them Penn Medicine Leadership Forums, really starts around the construction of an organizational challenge. So we don't offer a course in conflict management. We don't offer a course in change management. We bring together leaders around an organizational challenge like, how are we going to reduce avoidable readmission for congestive heart failure? And we say, who in the organization can touch that? And in the context of that problem, we facilitate discussions around creating followership, change management. So we actually develop and strengthen those competence in the context of a leader's daily work. So that was really I'd say the way that we propelled ourselves into this notion of accelerating innovation across the organization. We drilled that down to the front line through an initiative that we call Performance Improvement in Action. And that's where we teach the skills, the tools, and the methods for continuous process improvement and bring frontline staff together, again, around a particular organizational challenge. Every 90 days, we launch 10 to 12 learning labs around a particular organizational challenge, so we can begin to embed that within the organization. But those performance improvement in action teams really focused on reducing variation in practice, improving clinical outcomes while carving out costs. But it didn't really build in how do we create evidence. They were all around evidence-based practice. And certainly we can benefit from that, and we have. But this was bringing us to the next level. So we were actually looking for what's a method, what's a way that we can actually begin to create evidence in improving patient outcomes at a much lesser cost. So with that, we took a lead from some of the major organizations in the country that distinguished themselves in this field of innovation and owning the process of innovation. So if you think of an Apple, these are characteristics of those high-performing organizations that really know how to manage the process of innovation. And so what we did is we actually surveyed across our organization which of these characteristics do we do best, and where is there a gap that we need to get better. So in our organization, one thing we knew is while we were building skills like rapid divergence and problem redefinitions and selling ideas persuasively at the leadership level, we needed to drive that down to the front line. Around people in an academic medicine, and some of you may have this in your organization as well, we tended to select people on teams based upon what I would call the equity model. The equity model is I have to have a representative from every hospital. I have to have a physician, a nurse, a clinical pharmacist. And so we said, why don't we staff teams around who cares about this? Who has the passion and tenacity to solve this problem? And then the third is a characteristic not familiar to academic medicine, is how do we become more nimble? How do we can make decisions, not through committee structures, but decisions that actually drive better outcomes? So with that, Kevin and I had the great opportunity to select the dream team. We said, who cares about this across the organization? And one of those people on the dream team is Aaron Johnson. And so Aaron's going to talk to you about a method that we use to actually introduce and signal to the frontline staff a change in the direction we were going in accelerating rapid experimentation across the organization. It's called Your Big Idea, Penn Medicine's first innovation tournament.
So a helpful metaphor for describing how the Your Big Idea Innovation Tournament works is American Idol. So if you've ever seen this show, I've seen it once for research purposes. It starts off with thousands and thousands of people lining up around the block and filling up stadiums to get their shot. And then through a structured process that involves crowd-sourced voting and a panel of judges, through that process, the ideas go from thousands to hundreds to dozens, and then finally there's a winner. So if you think about that as the metaphor for how this works, our theme for this year was improving the patient experience at Penn Medicine, so it's broad and inclusive, and we thought that that was important, particularly as this is a tactic to begin to introduce these ways of thinking to a broad swath of our organization. The philosophy behind it is quite simple. The people with the best solutions for problems are typically the ones that are the closest to those problems. So we made a really concerted effort to have ideas come from all walks of life at Penn Medicine, clinical, non-clinical, inpatient, outpatient, staff at all levels. I'll go quickly through how it works. There's a submission process, and I'll get into these in a little bit more detail. There's an evaluation, and then a facilitator-led workshop is essentially the semifinals. There's some development and coaching around those ideas in preparation for a final round. So at the beginning of the process, we established a metric for ourselves. And we said our goal is to get 500 ideas in 6 weeks. And in fact, we got over 1,700 ideas in 4 weeks, to the point where we said, somebody has to actually read these things. So we have to kind of cut this off. So we actually cut it 2 weeks short. And it really exceeded our expectations, not just around volume, but around the energy and buzz that it created throughout the organization. I think we had hoped that it would achieve that, but I think that there was just a palpable sense of teamwork and camaraderie around this process, which is what made it so fun. So we built a website where people can go and they can submit their ideas. So after the 4-week submission process, there was a 2-week rating process, similar to a site like Yelp or Amazon, where you can go on and rate on a 5-star method, very familiar to people. So we had that open to the entire Penn Medicine community, and then there was a side panel of about 20 committee members who each had a responsibility to rate. I think it was 400 ideas. And so we ended up at the end of that 2-week process with 66,000 idea ratings, which again just blew us away. And we were able to determine through analytics on the website that about 6,000 people actually participated on this website from our community of faculty and staff, whether by submitting an idea or by rating an idea. And that represents about a third, which is a huge number. And we were all really excited about that, not just because, again, the volume, but because it meant that every one of those ideas got almost 40 ratings. So all of those 1,200 or so faculty and staff that submitted those 1,700 ideas, each of those ideas got a shot. So it wasn't 1 or 2 ratings, but a collection of about 38 ratings per idea. In round 2, so we took those 66,000 ratings, we applied an algorithm and invited 200 people to participate in facilitator-led learning labs. So on the top right, that's Christian Turwich. He's a professor at the Wharton School. He's a published author on the topic of innovation and innovation tournaments specifically. So here the interesting thing was 200 people entered these workshops with their own individual idea, and they each had 90 seconds to pitch their idea. There was a round of voting, and that number was whittled down to about a tenth of what came in. And then through an organic process, but also somewhat through design, people began forming teams around shared passions. And so what resulted from the workshop were 10 teams of about 3 or 4 people that then had shared ownership of the idea. And some of those people may not have had any idea that was even close to the idea that emerged, because through the workshop and the work that was done, the ideas evolved. And you know, many of those teams also had never met each other. So it was a great engagement opportunity as well. In preparation for the final round through the Penn Medicine Academy, we had public speaking training, and again, going back to those competencies that we're trying to build, those persuasive selling skills. We also provided teams with design and production support so that they can craft compelling PowerPoint presentations and videos in preparation for the finale, in which each of those 10 teams presented their ideas to a panel of about 15 leaders from throughout Penn Medicine, who then evaluated those ideas. We also had several hundred guests, faculty, and staff come and attend this event. They had an opportunity to text their vote, and that data was given to the judges, who were able to use that in their deliberations. So we had a tie. Out of the 1,700 plus ideas, 2 ideas won. The first was Patient Services Kiosk and My Penn Scheduler, which is an online scheduling system. Here the winning teams are pictured with our CEO, Ralph Muller. So these are 2 out of the 1,700 ideas, but I think one of the great things that came out of the tournament was those aren't the only 2 that we're doing something about. And so I'll give it back to Judy, and she can talk about some of the work that we're doing to implement some other ideas that resulted from the tournament.
So this whole notion of managing the process of innovation is also picking ideas during the innovation tournament itself. And so there were ideas that when we were scanning, we said these are quick wins. And so one was, you know, I noticed that my patients in chemo shiver. and they're cold. And in spite of the fact that they have a blanket, it'd be great if we had a blanket warmer. So this was really a way to signal to the organization that we can make decisions quickly that are in the interest of patients and improving the overall patient experience. So there were countless numbers of quick win ideas that we implemented in the course of the tournament. The second was it's an observation that we had. The best ideas didn't advance. And if you think about ideas that are transforming healthcare, reconceptualizing healthcare, you can imagine when people go to the website and they see one of those ideas, the first thing they say is, well, why would we do that? Because it's so far outside of their experience. And one of those ideas was from an RWJ fellow within our organization who stood up and she pitched her idea and she goes, I've been kind of running this little experiment with a group of Medicare and Medicaid patients. And when I was running my experiment, I discovered, in fact, that 80% of all of our readmissions came from 2 zip codes. And so I was sitting next to the chief medical officer and we looked at each other. I said, did you know that? And he said, no, I didn't know that. And what we discovered was her experiment was the deployment of community health workers with these 200 patients. And you may not be able to read this here, but that first trial of that experiment actually resulted in a 23% increase over the control patients in HCAHPS score, 15% higher level of compliance than control patients. And so what we did is we immediately picked that idea up. It didn't advance. We brought it to senior executive leadership. We invested some resources, and now we've expanded that rapid experiment to include 10 community health workers. That's showing great, great promise for our West Philadelphia community. I'm going to quickly go to what I call the 4 linchpins of how we think about sustaining this effort of continuing acceleration of our competence and innovation as an organization. One is the Penn Medicine Academy itself, that we continue to create learning labs that allow people to burn resources slowly and rapidly experiment, and then we make a decision to scale. And we also have the Center for Innovation that is comprised of behavioral economists, a chief innovation officer, that really helps facilitate. And they're the ones that own the process of innovation. So where are our best ideas coming from? How do we connect people? How do we partner with outside organizations to facilitate and advance our agenda? The third is really around aligning incentives to ensure that our leaders are rewarded for engaging in innovation and rapid experimentation. We do that through our variable pay for performance. And now are designing what we call shared success incentives so that we reward frontline staff for engaging in these rapid experiments as well. And then finally, the nimbleness comes with the executive leadership being able to deploy resources, money, et cetera, to invest in these rapid experiments. So lessons that we learned. The best ideas never come from the boardroom, never come from executive office. They come from the front line. And so providing them an opportunity to contribute in meaningful ways and to be recognized. And that what we're trying to do is apply the scientific model much faster, accelerate that model. And also appreciate and communicate what we call fast failures. Like many of your organizations, we're perfectionistic. We're in healthcare, right? And so when people's improvement initiatives aren't successful, they feel bad about that. And we celebrate those now. We say, we learned something from your fast failure. We learned that because we kept it to a small experiment, that we didn't deploy a lot of resources on something that didn't work. So we changed what we measured. We changed what we celebrate. People ask all the time, what is it that you did that got 1/3 of your workforce to participate in this innovation tournament? Well, we didn't do anything other than provide an electronic receptacle for those ideas and evidence that we were going to be successful. And they came to work when they won and saw something like a 2012 winner works here. 1/3 of our workforce, an incredibly strong employee engagement tactic. So with that, we have 32 seconds. I feel, does anybody old enough to remember Bud Collyer and Beat the Clock? Oh my gosh, this is what it is. So one question? Yes.
It has come up in the safety net hospitals. Philadelphia has 2 or 3 hospitals that, if they were to go out of business, Penn Medicine would be significantly impacted. So we have spent time. We haven't yet acted on transferring resources, but we have talked about would it be better to keep one of those hospitals afloat than it would be to add more wings or have an overcrowded emergency room. We've had a lot of hospitals in Philly close, most recent being one of the Tenet hospitals. The old Graduate Hospital, it was called, and we converted that into a rehab hospital. So we did try to keep it going. There's an urgent care center in there for the neighborhood. But I think it's an excellent point. It's true throughout Philadelphia.
And one of the things that came out of this tournament was the Community Health Worker Training Initiative that's in partnership with Temple, and that and with community health centers, federally qualified community health centers. So that's the sharing of this, and that idea is holding great promise for us. So with that, we go into the next room.